So I think we definitely need evidence-based strategies to improve our implementation of these therapies, but no matter what strategy that we undertake, I think we definitely need to overcome a culture in the United States of a tendency to not make medication changes when we see patients in clinic, and to overcome this high activation energy or clinical inertia when we see our patients. I think when we see a patient in practice, we often, when we talk about medication changes with them, both the clinician and the patient often emphasize the theoretical adverse events or risk of side effects with the drug, and obviously those need to be discussed, but I think we need to give at least equal weight to the potential risk of not trying a therapy or not trying to escalate the dose. There's risks of not trying, and those include potentially increased risk of dying, more hospitalizations, worse quality of life, and worse symptoms. So it's really a balance of we have to consider the risk of not trying these therapies and understand that even if a patient tells you that they're stable and they're stable in their exam, that does not mean they are low risk given the natural history of heart failure with reduced ejection fraction. I think there needs to be improved education to some extent on just recognizing that heart failure has a prognosis comparable to many forms of cancer. There is a sense of urgency for cancer among oncologists and cancer patients when they receive that diagnosis. Heart failure, I don't think it necessarily has that same sense of urgency among patients and clinicians. And I think if we could somehow infuse that sense of urgency, we would be more willing to make these medication changes, and we would have it more on our radar than we do currently. I think it's both. I think there needs to be improved awareness both on the clinician and the patient side. Again, recognizing that even when patients are stable, that is potentially a trap. We think we don't need to make any medication changes, they're doing fine, but recognizing that even among patients, for example, in the Paradigm HF trial, there's a sub-analysis, so even among patients with relatively mild symptoms, NYHA class 2, patients that had never been hospitalized, so these very kind of essentially stable, well-appearing heart failure with reduced ejection fraction, those patients had a 2-year rate of death, heart failure hospitalization, about 20%. So again, even a very high event rate in that subgroup with never been hospitalized before, very mild symptoms when they see you in the office, but again, something that we can't ignore is that event rate.